We're going to start out today with lumbar spine joint play palpation. Remember, joint play is a little bit of jiggle in the joint when it's in a neutral position. Joint play is clinically important because normal joint play is necessary for full, pain-free physiological range of motion. If you don't have normal joint play, you're not going to have that full physiologic range of motion. It can affect length-tension relationships. It can affect force coupling. That can lead to irritation of joints and soft tissues, and ultimately causes a lot of the presentations that we see with our patients. So first joint play we'll palpate is P to A joint play, and we're going to use our thumbs right over the facet joints and lumbar spine, and use your body weight. Once your thumbs are in place, use your body weight to spring in a posterior and anterior direction over those facet joints. Doing okay? Okay. If your thumbs bend backwards too much or hypermobile, you can use your thenars for this as well. You'll cover more than one segment at the same time. However, you'll still get a sense of that joint play using your thenars to perform this palpation. Alternatively, we can use a thumb and bent index. Works very nicely, reinforcing the thumb and bent index with the other hand. Just rolling in right over lumbosacral, and again using your body weight. I'm going to lean back a little bit so perhaps the camera can see that better, and just springing up in this P to A direction for P to A lumbar joint play prone. Next we're going to do counter-rotational joint play. Place your thumbs on adjacent spinuses, but direct the pressure towards the base of the spinous. Don't push directly across the spinous process. And again, use your body weight to lean in and then reverse directions for this counter-rotational joint play. Move up to the next level, and then reverse the direction of the thumbs, and again move up to the next level, and so on. So this would be counter-rotational joint play. You also can palpate for lateral glide by having the patient bend their knee and just relax it. Try and keep their thigh flat on the table. You can use your thigh to help guide the leg out. Make a contact with your thumb or your hypothenar or your digits along the spinous process, and then bring the thigh outward till the pelvis starts to tilt and you can feel the spinous start to glide. And then add a little overpressure to that. Come up to the next level. And as you go higher up in the lumbar spine, you may have to bring that leg up a little bit further to get the lumbar spine to glide at the higher levels. Try and keep the thigh parallel to the table surface. Okay. The next palpation I want to show you is for lumbar instability. It's a lumbar stability test. It's called shear stability. What we're going to do is have our patient move down towards the end of the table. Let me push this in. And have them hold on and slide down a little bit further. Make sure their weight is on their feet. And in this position, the segment that you feel is unstable, usually L4. L4 is more commonly unstable than L5. Make a hypothenar contact over that segment and spring from posterior to anterior, trying to elicit the patient's complaint. All right. Then have the patient lift their toes up off the floor a little bit, and then spring again, and lower the feet back down and slide back up for me. If the patient's pain is improved or diminishes or goes away when the feet are off the ground, that's a sign of instability. What you've done is you've activated the core when the patient raises their legs up. That includes the transverse spinalis, the multifidi, and the rotatories. and pelvic floor, diaphragm, transverse abdominis muscle. All the intrinsic core is activated, and it helps to stabilize the area. So if the pain diminishes, it's consistent with there being lumbar instability. That's important clinically because it would be a relative contraindication for certain techniques. You're not going to want to do HVLA on a unstable area. There are other alternatives to treating in an area like that. Also, it will cue you into the fact that the patient's going to need that type of rehab as well. The intrinsic core and core stabilization exercise will benefit that type of patient tremendously. So for the seated palpation, I'm going to start with my thumb against the spinous process. I'm going to rotate to the left. My thumb is on the left side. Bend forward just a little bit. And I'm going to spring across for left rotation, range of motion, and end feel. From the same position, I can do left lateral flexion, apply some overpressure. I can go to the segment above, left rotation, overpressure, left lateral flexion, overpressure, segment below, left rotation, overpressure, left lateral flexion, overpressure. For flexion extension, I'm going to use a thumb, reinforced digital contact, or I can use the entire back of my hand, or just use a thumb bent index contact. Bring the head back a little bit, extension range of motion, and spring forward. Extension range of motion, and overpressure. Extension range of motion, and overpressure. For flexion, I'm just going to flex my patient forward, feel the inner spinous spaces open, and apply some overpressure. Come back up, get my digits in the inner spinous spaces, flex my patient forward, and apply some overpressure. Go ahead, bend forward, flex my patient forward, and apply some overpressure. You can also do this similar palpation nicely in side posture. Let me have you lie on your right side. And basic side posture position. Turn your face up a little bit. There you go. So from here, what I could do is square off your shoulders for me a bit. Okay, just turn your head up towards the ceiling. Just palpate those inner spinous spaces. Use the lower extremity, the knee, to create flexion, and then extension. Feel the inner spinous spaces open. Feel them close down. Move up to another level. Feel them open. And feel them close down. Come up again. Feel them open. And feel them close down when you apply extension. Curl both legs up for me. And bend your hips. There you go. This is also a nice position for assessing lateral flexion. Right? Get my digits right on top of the spinous processes, tip the pelvis up, and see if those spinous processes move in lateral flexion. Just work my way up the spine. And that's a nice alternative for palpating that lumbar spine lateral flexion glide and play. Now we're ready to move on to our lumbar manipulation. The first adjustment we're going to do is side posture resisted hypothenar mammillary push for a rotation restriction. All right. You guys familiar with the term resisted? What it means? You've heard it before, resisted? All right. So in this case we'll be adjusting, let's say L3, L4. All right. I'm going to make an L4 contact. It's going to be an L4 mammillary contact. It's going to be a drop. All right. So my patient's in a side-lying position. The torso is rotated to the right. The pelvis is actually counterbalancing that to the left. All right. So I'm going to step over the thigh. My knee is free in the front so it can bend. I said I was going to make an L4 mammillary contact. All right. So let's find L4. There's the iliac crest. We'll call that the L4 spinous. We'll call that the mammillary of L4 right there. So I'm going to make that mammillary contact. I'm going to bring this elbow down a little bit so it's just off the midline. I'm going to roll that underneath me, and my vector is going to be P to A and S to I. So I'm actually pulling down a little bit. My elbow's tucked in. Torso is rotated back, and my drop is transferring my body weight through my arm, and my front knee is bending as I'm dropping down. I'm letting my thigh come down on the patient's thigh as well. All right? So that was the resisted adjustment, and hopefully it should look like a lot of the adjustments you've been doing that you're already calling a mammillary push. What makes it resisted? Well, it's really just a matter of semantics and perhaps a little bit of biomechanics. You can straighten that out there. I contacted L4, right? And I'm calling this an L3-L4 right rotation restriction because L4 is actually, since I'm on the mammillary, L4 is going to will get rotated towards the floor, which is the left side. Everyone in agreement on that? All right. But above L4, L3 is actually going to rotate the other way. Right? So my thrust, in effect, is resisting the rotation of the torso. Right? So that's why it's called a resisted adjustment. Now, this is what I'm going to state next is my opinion. What's the clinical significance of that? How much clinical significance does it have? I'm going to say it has very little or zero clinical significance, right? It's just a way of speaking about what we're manipulating, how we're manipulating, what we're adjusting. You've been doing that adjustment all along, right? You're causing counter rotation in your setup. You're making a contact. Let's look at the next adjustment, and then we'll engage a little more conversation about it. The next adjustment is a side posture assisted hypothenar spinous push for a rotation restriction. So let's use the same setup, right? So instead of making a mammillary contact, I'm going to make a spinous contact. But everything else is going to be the same. The counter rotation is the same. The left side is down, the right side is up. Bring the foot into the popliteal fossa. I'm even going to set it up as the same type of a drop technique. So I step in. Let's call this an L4. Since I contacted the L4 mammillary, let's stay on L4. So there's the L4 spinous. I'm going to come in with my hypothenar on the L4 spinous. I'm going to maintain that rotation right there, that torso rotation. Going to step in, keep the elbow in, and again that drop's going to come from getting my body weight into the adjustment. Just like that. You okay? All right. So that's the assisted L4 spinous. What makes that assisted? All right? What makes it assisted is that I'm on L4 and my thrust is creating the same movement that the torso is trying to create. So L4 is rotating to the right, and I'm rotating L4 also to the right with my thrust. So my thrust, in effect, is assisting the movement, whereas when I was on the mammillary before, my thrust was resisting the relative movement of the torso. So when we're talking about resisted types of adjustments, we're on the lower segment, moving the segments above, relatively speaking. When we're doing assisted types of adjustments, we're on the upper segment. I was on L4. We would consider that an L4, L5 adjustment. Whereas the mammillary contact, I was on L4, we would consider that an L3, L4 adjustment, right? So that's really all there is to it. It's not really all that complicated. It's a matter of understanding the semantics of it. When it comes to our profession in general and boards, right, when you take Part 4, you're doing some of these adjustments, you're looking at these listings, or if you're answering questions. You guys have done Part 2 already? So you've answered these questions already in Part 2. Some of you will go on to take Part 3. If you're answering any kind of questions like that, remember this. There are no resisted types of questions or setups on any of the boards, right? There are no resisted You'll never be asked to do a resisted adjustment that I know of on any of these types of tests, nor will any of the questions really relate to that either. All right? It's a lot more traditional. It has, and it's not to say that this is contemporary. This stuff has actually been around a long time. Researcher called Sandoz, if you look in the literature, Sandoz, this goes back into the 70s, I believe. The first time you'll hear the terms resisted and assisted movement. All right? We'll come across this again when we do cervical thoracic adjusting. Anytime you're doing any type of counter-rotational movements, you can always talk about assisted and resisted. Okay, okay, let's look at some lateral flexion adjustments. The next one is a side posture hypothenar spinous push for a lateral flexion restriction. All right, Doc, would you mind just sliding that up so I can see the bottom of that as well? This would probably be on the bottom. Yeah, just go up a little further. Well, not quite that far. Yeah, there you go, right there. And then in a moment, just go up one higher. All right. So side posture hypothenar push. So we use the same setup. Right? This is actually done more appropriately when you have a thoracic or a lumbar piece that can drop away, right? Because we're going to be creating lateral flexion on the upside, right? So this would be considered for a right lateral flexion restriction, right? And I bring the foot into the popliteal fossa, same basic side posture position. Step over the thigh, thigh on thigh, my front knee can move. Right. If your patient's very lordotic, bring the leg up a little bit so you can get a little purchase on the spinous so there's not too much lordosis. Slide in with your hypothenar, right? L3, L4, L4, L5, wherever it might happen to be. Get the patient underneath you. Bring the patient into a little bit of a lateral flexion load. I like to maintain some rotation in there, and again, it's that body drop that gives you the force generator, throwing your body weight at it. All right, so that's a hypothenar spinous push. We also can do this with digital contact, so similar. I actually prefer to add a little rotation to this just for patient comfort level. With the digital contact, I won't pull this down as much, or at all for that matter, because you'll notice I'm going to use the heel of my hand to help me create some of that lateral flexion, right? And it's going to look like this. Everything else is the same, basic side posture position. Going to step in with my front knee so that it can bend. And this is going to be a digital contact, right? But the heel of my hand is going to assist me in pushing the area into a little bit of lateral flexion. Remember, the intersegmental lateral flexion is quite small, so I don't need to create a gross movement of lateral flexion for this. So there's my digital contact. Lean into it with the heel of my hand. Maintain some of that torso rotation. And again, I let that front knee bend as I create that force generation using the digital contact. Can you just pass me that roll right over there, the blue roll? And I'm going to have you, I'm going to just lift you up so I can get this underneath you. You know, lie on that. There you go. Having the roll in place here will help me to create lateral flexion towards the table. In other words, on the downside. So straighten that bottom leg out. Create some lateral flexion on the downside. So what that does for me, and you can see it as I push that down, it creates some left lateral flexion. Some left lateral flexion. So from here I have a number of choices. I can use a mammillary contact, or I can use a digital contact to create this movement. Can you just slide that up one more the other way? Just want to see the last one on the, yep. Hypothenar spinous push, side posture, digital. Okay. Okay, come back up. Right there is good. So the side posture hypothenar mammillary push, This is going to be for left lateral flexion. The roll gives me that, and the mammillary contact also gives me that. So again, everything else is the same in terms of the setup. Let me have this arm. There you go. Bring this down a little bit. Contact the mammillary on the upside. The vector is going to be I to S and P to A. So it's like I'm almost lifting that segment up, right, into left lateral flexion. Thigh on thigh, elbows in, and my force generation comes from me throwing my body weight at that. Okay, and I want to make sure that that leg bends in the front.